Thank you very much for inviting me to give this presentation. Now, advance to the next slide here. Now, most people believe that testing for SARS-CoV-2, the virus that leads to COVID-19, is a very important component of getting the world back to normal. So, for example, Senator Elizabeth Warren said in a tweet on March 26th that restarting our economy will require one thing above all else: testing. Testing to show who's currently infected, testing to show who's had the virus and is immune. Social distancing won't end because it's Easter. It will end when we have sufficient testing. Governor Andrew Cuomo said that it's all about testing, testing, testing. This was back in April. And even myself, I've got into tweeting about testing. And I said back on March 13th that COVID-19 testing, not enough tests for all we would like to screen. How can labs solve this problem? Well, use specimen pulling, otherwise known as group testing, like is done already for sexually transmitted disease testing. So what exactly then is group testing? I had hoped to show you a video of Nebraska Governor Pete Ricketts explaining this to the press on March 24th, describing what we're doing in Nebraska. Unfortunately, through the Zoom connection, live action video doesn't work very well. So instead, what I will do is take advantage of Governor Ricketts' hand gesture there to help explain what group testing is and how we're doing it in Nebraska. So simply what we're doing is we're amalgamating or putting together portions of 5 specimens from different people into a group. And we test this group as if it were a single specimen. So if a group tests negative, then that says all 5 people within it can be declared negative. So notice it only took 1 test to determine that 5 people are negative, where it would take 5 tests to determine that with testing everyone individually or separately. Of course, a group could come back positive. And in that case, what we need to do is retest everyone individually to determine who's positive and who's negative. Now, the reason why group testing is important right now is because when it's applied in an appropriate setting, such as when the overall disease prevalence is small, and applied with an appropriate group size, one will reduce the number of tests when screening a large number of people. And by reducing the number of tests, that's going to free up resources that you would have used otherwise to now test more people. And so labs are very interested in increasing their testing capacity, and group testing can do that. So you may have seen group testing discussed in the media and in a variety of outlets. Just recently in the Washington Post and the New York Times, it was talked about because a number of people close to the White House, such as Anthony Fauci, have been talking about group testing. It's also appeared in a number of peer-reviewed publications, where the first 4 papers that actually use specimens to show that it worked are listed here. And in particular, this Hogan et al. Includes 3 researchers from Stanford. And there's been hundreds of preprint server papers that have been put out there. Here's an early one that was put out there that's quite good, and the first author is at Stanford right now as well. Now, group testing goes by a number of different names. In statistics, we generally refer to it as group testing or pool testing. But in medical applications or in labs, you rarely ever hear the phrase group testing used. Instead, it's pool testing or specimen pooling. And the origins of group testing can be traced back as far at least as 1915. But most people usually reference the origins corresponding to Robert Dorfmann in a paper that he wrote for the Annals of Mathematical Statistics in 1943. Dorfmann was working for the US government in DC, and himself and a number of other individuals were talking about how they could screen U.S. Army initiates for syphilis in an efficient manner. Dorfmann put these ideas together and then published them. And essentially, the way that I describe how we're doing the testing in Nebraska is Dorfmann's idea. So we often refer to that as Dorfmann testing. Interestingly, in medical applications and for labs, very often this is the only way that people know about of how to use group testing. So it's the only group testing algorithm. And that's actually too bad, because there's a lot of other group testing algorithms that have been developed since 1943 that can actually be a lot more efficient when applied. And what I mean by efficient, lower the number of tests needed, increase the testing capacity more. Interestingly as well, group testing has been suggested in the past for previous pandemics. So back about 10 years ago, you might remember H1N1 influenza virus pandemic. Didn't really affect the United States much. It did other parts of the world. And Van et al. Had a very nice paper discussing how group testing could be used for that particular setting. Now, in terms of the statistical aspects then of group testing, typically in terms of research, we divide it up into two different research problems. The identification problem, where we're interested in coming up with the expected number of tests a particular group testing algorithm would take to implement. Labs need to know this information so that they can implement it, so that they can gather the necessary resources to implement it. And then along with the expected number of tests, well, what's the best group size to use to implement group testing in the most efficient manner? One can also look at expected accuracy of a particular group testing algorithm, and there's various other group testing algorithms, which one's best to use for a particular situation, at least in a statistical sense. Now, the second part to statistical research for group testing is what's known as the estimation problem, where you would like to estimate an overall prevalence of a disease, or maybe the specific probability of disease for a particular individual as a function of their risk factors. Now, the actual estimation process in this kind of a setting is not necessarily straightforward. And the reason being is because these group testing algorithms give kind of a unique kind of data, where you will have maybe a particular person contributing to multiple groups. So you have essentially multiple combined observations for a particular person. Also, infectious disease assays, unfortunately, are not 100% accurate. And so if you're going to get a good estimate of like the disease prevalence, you better take that into account. Take into account like the sensitivity of the assay that's doing the test. Now, I will focus here on the identification part of the COVID-19 pandemic. And I will talk about how group testing is being used now. The statistical aspects are really not too difficult. But I also will talk about how group testing could be used more efficiently. Okay, so let's talk about Dorfmann testing. Again, this is typically thought of as the easiest group testing algorithm out there to implement. You test in a group. If it comes back positive, then you go to individual testing. So we're going to let T be the number of tests required for a group of size I. It's a random variable. And T is either equal to 1 if the group tests negative, or I plus 1 if the group tests positive, where that I part comes from these I retests that would occur if the group is positive. And Dorfmann testing is done across stages. Stage 1, where you test in a group. So for stage 1, let's define G sub 1 as the group binary test result with levels of 1 for positive, 0 for negative. And G tilde 1 will be the true group binary status. Again, we need to define both because infectious disease assays are not necessarily 100% accurate. we'll let pi tilde sub I be the probability that the ith individual is truly positive. And we can define the actual test accuracy then as SE1 for the sensitivity of the group tests, and SP1 as the specificity of the group tests as well. With that then, we can simply come up with then what the expected number of tests would be. And the 1 here corresponds to that first test of the group. And we do I more tests if that group tests positive, and the probability of that occurring is denoted by the probability of G sub 1 is equal to 1. Through some derivations, one can show then what that probability is in terms of the sensitivity, the specificity, and the probability individual is truly positive. Now, often you see some simplifications with this expression. For example, maybe you don't have a way to differentiate the probability someone's positive. So maybe you might want to work with an overall prevalence. Let's call it with pi tilde. And there's a simple then simplification to the expected value of t. Our original expression had the probability of the group testing negative, the true probability, and we simply replace it with 1 minus pi tilde raised to the ith power. Another simplification that you often see is that sometimes you might want to say, well, give us a best case scenario. Sensitivity, specificity is equal to 1. And our expression for the expected number of tests then simplifies further. Now, one could also derive then the expected accuracy of dorfmann testing. And this isn't going to be necessarily equal to the accuracy of simply applying the test to individual specimens. Unfortunately, due to time restrictions, I've decided to remove that aspect from my presentation. But I will tell you instead is that there are functions in R that will calculate measures like accuracy, the expected number of tests for you. Myself and a number of my colleagues, we've put together a bin group 2 package to be essentially the home of group testing in R. And we have a number of functions that will do these calculations for us. If though you're interested in seeing the actual mathematical expressions or seeing how they're actually derived, here's a number of references for that. In particular, I recommend this Kim et al. Reference from Biometrics in 2007. One of the co-authors is Michael Hudgens, who's a professor at University of North Carolina Biostats. Okay, so let's talk a little bit more detail about how we're doing the testing in Nebraska, how we concluded that group testing will indeed work for this particular situation. The corresponding work that I'm going to discuss is in a paper that I'm a co-author on that's in the American Journal of Clinical Pathology. And we first started exploring group testing in mid-March. This testing is done at the Nebraska Public Health Laboratory, which is on the campus of the University of Nebraska Medical Center in Omaha. And at this laboratory, the CDC's assay for SARS-CoV-2 is used. And this is a nucleic acid amplification test where there are a number of cycles used to amplify the genetic material that corresponds to the virus. And if some threshold is crossed prior to 40 amplification cycles, we say that indeed we have a positive. Otherwise, we have a negative. And if we do have a positive, what's reported back to us then is the cycle threshold, or CT value. And this tells us the number of cycles completed before we cross the threshold, simply. This is closely related to the viral load, but it's not exactly. The higher the viral load that you would have in an actual specimen, the lower the CT value. So in other words, the amplification process takes less cycles. Overall, the process takes 4 hours, about 4 hours to complete. And if you'd like to see more detail about what's actually going on in the lab, there was a nice article in the Omaha newspaper back in May about that, where they actually have a 2-minute video showing what's going on in the lab, how this test is being conducted. Now, in order to put group testing into clinical use, there's generally 3 steps that one needs to follow. First of all, determine, well, what will be the optimal group size to use? In other words, what's going to be the most efficient? What's going to lower my expected number of tests, let's say per individual that I'm interested in screening the most? And so here's our expected value of T equation that we saw before. It's written in terms of an overall prevalence. And we need to decide, if we're going to work with this expression, well, what's the value of pi tilde? And so before we started exploring group testing, a lot of individual tests were performed. And we found from those individual tests, from the population of people that were being screened, that the observed positivity rate was 0.05. So that seems to be a good place to start for what we should use for pi tilde. But we also need to decide, well, what do we use for sensitivity and specificity, though, in this equation? In other group testing applications, excuse me, typically we have information about large clinical trials that were performed on an assay to verify that indeed it worked. And typically what's done is that these sensitivities and specificities that you get from these large clinical trials, you use those as constants in your expected value of T expression. Unfortunately, we didn't have that information because the assay was very new at that time. So instead, what we had to do was we looked at 2 different scenarios where we use a sensitivity of 1 and a specificity of 1, so a best case scenario. But we also looked at a case of a sensitivity of 0.95 and a specificity of 1. That 0.95 comes about through essentially how this assay is developed. And it's developed in a way that a limit of detection set so that essentially 95% of true positives with a low viral load are found. And so we thought, okay, that would be a good case to look at as well. Then with our expression, then we want to minimize the expected number of tests per individual to find what the optimal group size, or I, would be. There isn't a closed form expression for this minimization, but there is a nice approximation that one could use to find this optimal group size. And this approximation works when you have a sensitivity of 1, specificity of 1. What you can do is use the ceiling function with 1 over the square root of pi tilde. But still in settings where you don't have a sensitivity of 1, or maybe you just want an exact answer, well, how can you do it? Fortunately, there's an app for that. So myself and my PhD student, Brianna Hitt, have constructed a Shiny app for pool testing that's available on my website. Our intended audience for this app was actually for laboratories that perform STD testing. From our experience, we found that they really could use something like this. Group testing is used a lot in this setting. But also we wanted to introduce them to more efficient group testing algorithms than simply Dorfman testing. We thought, oh, this would be a good way to do that. So this is a screen capture from the app. And if we go to the left-hand side here, if one would actually click on hierarchical testing, optimal configuration, you get to this web page. The hierarchical testing corresponds to actually Dorfman testing. Dorfman testing is a special case of hierarchical, and you'll see why coming up shortly. The optimal configuration says, well, what's the optimal group size to use? Simple. So in this app, we can simply specify how many diseases are we testing for, what's the overall prevalence, sensitivity, specificity, how many stages for the group testing algorithm, Dorfmann testing, there's 2, and where do you want to look for the best group size, from 3 to 20, let's say. Once we enter that, we click on calculate, and then right below this table, we have the results given to us. In this particular situation, the optimal group size is 5. This would result in an expected number of tests of 2.13, and on a per individual basis, it would take on average about 0.43 tests. If you were to do individual testing, that would be 1 test per individual. And so if we were to compare this to individual testing then, simply, well, there's a 57% reduction in the expected number of tests. So that's good. And then to put it in a perspective that a lab is really interested in right now, this would lead to a 135% increase in the expected testing capacity relative to individual testing. And if one were to also look at a sensitivity of 0.95, you would happen to get the same optimal group size too. Okay, so this app has been getting a lot of use. And so for about a recent 2-month period, what we see here with all the red dots is all the locations around the world of people who've actually used the app. In total, there's been about 69 countries and visitors from 42 different states in our country. Okay, so step 1, find that best group size. Step number 2, let's determine if there is a dilution problem. This is a very, very important concern for laboratories. So what a dilution problem means is that, if we have a group of size 5, each individual specimen that's part of that group now is a smaller portion of the specimen that's being tested in comparison to if each specimen was tested separately. So because of that, one may be concerned that now you might miss the virus, since now you're working with a smaller overall specimen that's part of the whole. And so essentially, each specimen is diluted by all the other specimens. So to investigate that further, what was done was that 25 groups were formed where 4 known negatives were essentially put into the group. These were known negatives from doing individual testing. And 1 known positive was put in that group where the known positive had a low viral load to begin with. So in other words, a high CT value. In all 25 cases, the assay was still able to declare a positive for the group. So that's very good. And but it took a few more cycles to get to that, to say, yes, that is a positive. On average, maybe about 3. So, what can we do? Well, fortunately, the amplification usually happens much earlier than 40 in most situations anyway. But still, what we can do is run the test for now 45 cycles instead of 40. And if that comes back positive, well, let's do the retests. And in the thousands of tests that have been performed since we validated the procedure, this has only happened a few times, and only once was a positive individual found through the retesting of individuals. So then step 3 of the process is to actually try it out with clinical specimens. So after about the first 6 days, we observed about 0.42 tests on average that were needed per individual to determine their positive or negative status. Again, from earlier, the expected number of tests per individual was 0.43. And again, thousands of more tests have been done since this time period, and similar results have occurred. So that's how we're doing it in Nebraska. But we might be wondering, well, can we do better? Could we reduce the expected number of tests even further? And the answer is, well, yes, we can. So group testing, in terms of the types of algorithms that are available, are typically divided into two categories. One of the categories is called hierarchical group testing. Another name that you will see outside of statistics sometimes is called adaptive group testing. And this kind of a testing algorithm basically tests individuals over multiple stages in non-overlapping groups. So for example, Lowe's et al. In a Lancet paper that appeared in April described their three-stage algorithm for SARS-CoV-2 detection. And what they did was they tested using an initial group size of 30. If that group tested negative, everyone was then declared negative in that group. Otherwise, a second stage of testing was performed where all the individuals were separated into 3 groups of size 10. These are non-overlapping groups, meaning each person is in one and only one group. If one of these stage 2 groups tests positive, then a third stage is done where each individual is tested separately. Algorithms can have more than 3 stages. In actual application, I've only seen up to 4 stages actually used. And Dorfmann's testing algorithm is a 2-stage algorithm. So let's define some notation with this. So let's let S be the number of stages. G sub Sj is going to be the group test result for group J at stage S. M sub Sj is going to be the number of subgroups that group J at stage S is divided into if it tests positive. In other words, in that Lowe's et al. Example, they started with a group of size 30, and then 3 new groups would be formed if that group tested positive. So in that case, M sub 1 would be 3. C sub S is the number of groups in stage S. And then from that, we can come up with a relatively simple expression for the expected number of tests if you start off with an initial group of size I. And this expression here is 1 for that first test, for that first stage group. Then we sum over all the stages except for the last one, because no more testing is done after that last one. We sum over all groups within a stage. And what we're summing is the number of tests that will occur if G sub Sj tests positive. And we multiply it by then the corresponding probability that this occurs. If you want to see expressions for this, because the more stages you have, the more complicated it gets. If you want to see expressions, here are some references. Instead, what I will tell you is that this probability here is a function of the sensitivity and specificity of the assay. It's a function of the probability the individual is positive, and it's also a function of all the group sizes now that you have to keep track of. Well, what about these group sizes then? Well, to find the optimal set of group sizes, what we can do is minimize the expected number of tests per individual. If you have a 3-stage algorithm, as long as I is not too large to begin with, let's say not more than about 70, you can do a grid search to look at over all possible group sizes throughout the stages. If, though, you do a 4-stage and higher algorithm, then you need to go to some more sophisticated methods and use some kind of optimization search routine. So let's do some comparisons to what Lowe's et al. Had for their group testing algorithm. Unfortunately, in their paper, they didn't give any guidance for why they chose the group sizes that they ended up using. To make things simple here, we're going to let a sensitivity and specificity be equal to 1, and we'll work with an overall prevalence of pi tilde. So here's a plot that gives you some idea of how good these group testing algorithms can be. On the y-axis, we have this expected number of tests per individual. So we want this to be as low as possible. On the x-axis, we have an overall prevalence. The black line corresponds to what Lowe's et al. Did for their paper. And so if we compare that to Dorfman, we can see that for most prevalences, the Dorfman algorithm, which is over 2 stages, will actually be better than how Lowe's et al. Approached it. If we look at then and this is, in terms of Dorfman, this is with the optimal group sizes used at each prevalence. If we also use optimal group sizes for a 3-stage algorithm, we can see that we can also get a better or further reduction in the expected number of tests. And in fact, what Lowe's et al. Did in their paper is actually never optimal.
Hey, Chris.
Yes.
Quick question. So it seems like a complication here would be that the more stages you're doing, the longer it's going to take to get the test results back. Is there any, can you talk about the considerations there?
Sure. In fact, you are going to foreshadow my next slide.
Okay, great.
So
yeah.
if I can wait till the next slide, then I will talk about it.
Thank you. I'm going to turn my video off because I have crappy internet. Sorry.
So I think an important thing for especially those who are maybe new to group testing and why people are interested in this is if we take a look at this increase in the expected testing capacity then. So in Lowe's et al., they actually had an observed prevalence of 0.0193. And we can see that they could have an increase in expected testing capacity of about 300%. But if you use the best possible 3-stage algorithm, you can get that up to 400%. Okay, so let's now also talk about a different way to do group testing. These are called non-hierarchical group testing algorithms. In areas outside statistics, often you will hear this referred to as non-adaptive group testing. And the idea here is in your first stage of testing, let's try to test individuals in overlapping groups. And the reason that you want to try to do that is to try to reduce the number of retests or more stages that you would need to do. So ideally, what we'd like to be able to do is, test everyone in maybe 2 or 3 groups at the very beginning, and then hopefully, maybe if we did do a second stage, we don't have to do much in terms of that many tests, or retests, I should say. So a very commonly used group testing algorithm that uses this non-hierarchical approach is called array testing, and that's the only non-hierarchical method I'm going to focus on here. And the way that array testing works is imagine that you arrange specimens in a grid. So, if you can imagine with this diagram, maybe you have a rack of test tubes and you're looking down from above on that rack so that each of the circles represent the tops of the test tubes. An alternative way to think about this too is, maybe if you had a microplate that was this particular size, the circles then represent the wells of the plate where there's specimens. And the way that array testing works, it says, okay, let's form groups by row, let's form groups by column throughout this array, and then we perform tests on these row and column groups. Now, where the row groups and the column groups test positive, their intersections, that says, okay, why don't you do some retesting there? And so in this particular situation, we have 4 individuals out of, in this case, would be 100 total specimens that we would need to actually retest. All the other individuals then can be declared negative with just simply 1 stage of testing. So let's look at some notation associated with array testing. Let's let T be the number of tests for one array. We're going to let D sub ij be the binary result for whether a retest is actually needed for cell ij. And the expected number of tests then for one array could be written like this, where we have the number of column tests plus the number of row tests plus then we're going to sum over all the cells of the array. And what we're summing then is this probability that a retest is needed. Well, when is a retest, though, needed for cell I and j? Well, as we just saw, it's when row I and column j test positive. But unfortunately, it gets more complicated because, again, infectious disease assays are not 100% accurate. So you could actually have a situation where row I tests positive, but no columns test positive. You could have column J test positive and no rows test positive. So unfortunately then, this makes then the derivation of what this probability is a lot more complicated. And in fact, I don't think I could give the whole expression on just one slide. But I will tell you is that this probability is a function of the sensitivity, the specificity of the assay. It's a function of then the probability of disease for the individual represented by cell ij, and it's also a function of the row and column sizes. In terms of array testing research done in statistics, probably the first paper was in 1994. But if you want to look more into this, again, I refer to you to Kim and Hudgens' paper that was in Biometrics in 2007. It's really a good paper. Now, there are other ways to implement array testing. For example, in this Kim et al. Paper, they talk about including a master group at the beginning of the testing process. What that means is, suppose you could actually form a group at the very beginning of all the specimens that are in that array and test it. If it comes back negative, you're done. If it comes back positive, then you go to the row and column group testing. One problem though with that is your master group size could be so big that essentially this dilution problem that I talked about before can cause a problem. So let's look at some comparisons then. So on my y-axis here, this time I've put the reduction in the expected number of tests. What this is simply 1 minus the expected number of tests per individual. And this reduction is in comparison to individual testing. So the x-axis then is disease prevalence. The red line, again, is Dorfmann testing. And so we can see, for example, at an overall disease prevalence of 1, the expected number of tests is, if I can draw it straight, is approximately, the reduction in the expected number of tests is approximately 80%. This is using an optimal group size. In this case, it would be 11. Now, we can also compare to the optimal way of using three-stage hierarchical, the optimal way of using array testing. And we can see since these corresponding lines are above where Dorfmann testing is, it will reduce the number or the expected number of tests even further. And once again, let's focus on this increase in expected testing capacity. And so we can see that through using three-stage hierarchical, using array, we can increase expected testing capacity by over 600%. So let's look at some alternatives or maybe extensions, you could say, of what we just talked about. What we would like to be able to do is differentiate amongst individuals who are at higher risk for COVID-19, perhaps due to their behavior, perhaps due to symptoms that they exhibit, or maybe due to some kind of laboratory observation that's made on their specimen. I'm not for sure for this particular application of group testing what that would be, but I've seen it in other applications of group testing where that does occur. So if we could do that, then we could work with these individual probabilities of being positive for a disease that I've been showing you so far, but really haven't used in any of the examples. And perhaps then we could take advantage then of differences in these risk probabilities. And if we do that, we can then implement what's called informative group testing, where we want to use information to guide us to how we can make the group testing process more efficient. Other names that I've seen for informative group testing include generalized group testing, risk-based pooling. Now, as you might imagine that if you are going to use this extra information, the testing process is going to be more efficient. And indeed, that does occur. So you're going to reduce the expected number of tests even further. In terms of statistical research in this area, there was some origins back in the 1970s, but it didn't really necessarily say how one would actually go about implementing this. And so my paper that was in JASA, and also I'm a co-author on this paper by Chris McMahon, or these papers by Chris McMahon, that talk about, well, this is how we can actually implement it. And if you're interested in this, take a look at those two biometrics papers. Now, people who work at labs think this way in terms of let's differentiate amongst individuals who are at higher risk. And because of that, there's been research in medical literature too, corresponding to these ideas. And here are two particular papers on that. And so to give you an idea of how this would work, let's think of like informative hierarchical testing, how we would go about doing that. And we're going to simplify things greatly. So imagine if we somehow knew that the probability an individual is positive for disease, somehow we know it's either 0 or 1, nothing in between. And let's say we live in a perfect world, there's no testing there. But we still want to do testing. And so if we were to implement group testing in this scenario, the best way to go about doing this would be to say, okay, let's take all these people who have a probability of 0 being positive, let's put them all together in one group and test that entire group, because we'll get done with them with just one test. Now, those individuals, though they have a probability of 1, well, we should even group test them. Let's just test them separately. Of course, in actual application, testing error is possible. We don't know if someone's positive or negative, but the same principles apply about how to efficiently apply these informative group testing ideas. For low-risk individuals, let's put them in larger groups. For high-risk individuals, let's put them in smaller groups. Well, still, how do you get this pi tilde sub I? Estimate with the regression model. Fortunately, in high-volume clinical specimen testing settings, such as the one that we have right now with COVID-19, there's usually large amounts of data available, so you can get a nice model to get at these pi tildes. For example, with respect to Nebraska, we have information on anybody who's being tested regarding symptoms. We have also information about risk factors too. And so I was really looking forward to applying some of these ideas to my state here, but unfortunately we weren't able to, and that's because of the data quality. With each test that's done, a test request form is filled out by the clinic that's actually taking the specimen, and how they were filling out the forms unfortunately wasn't consistent. And so we couldn't really use that data. This was back in April and May when we were trying this out. Fortunately, I just recently heard actually a couple of days ago that some of those problems have been worked out, and we're going to look at this further, and hopefully we can actually implement it. But since I don't have an actual example to show you, let's look at, well, what if we did actually have an example, or what if scenario, and we're going to model this on Lowe's et al. Again, for their particular setting, let's use a prevalence of 0.0193. For their particular group testing algorithm, they had an expected number of tests per individual of 0.25. Now, we need to somehow get these probabilities of disease different, but we want to do it in a controlled manner for every individual. So let's say that pi tilde sub I now has a beta distribution, and we're going to parameterize that beta distribution in a way so that the expected value of pi tilde sub I is essentially this overall prevalence of 0.0193. And to examine how this will work, we're going to use the expected value of order statistics from this beta distribution simply as the probabilities of disease. And we're going to look at 3-stage hierarchical testing algorithms, where in stage 2, we're going to always work with ordered individuals by these probabilities and successively put them into groups. Okay, so let's suppose, or what if alpha was equal to 1? In this particular case, the best group size to use for at the stage 1 would be 20. Then in stage 2, if you need to do this, put the 8 individuals with the lowest probability of disease in a group. The next 5 individuals with the next lowest probabilities of disease in a group as well, and so on. And in comparison to what Lowe's et al. Did, we get a 24% reduction in the expected number of tests per individual. Well, what if alpha is 0.1 though? Here you can see now we get a 44% reduction. And you might be wondering, okay, well, are these alphas realistic? Well, here are some beta distribution quantiles that gives you an idea of the spread of these probabilities that would actually occur. So if alpha is 0.1, we see we're a little bit above 0 for the 0.01 quantile and 0.29 for the 0.99 quantile from the beta distribution. Now, I have used this technique relative to group testing in a sexually transmitted disease setting, and having probabilities with this kind of spread are very, very reasonable. Let's look at another alternative. Let's talk about multiplex assays. In this context, they are simultaneous tests for multiple diseases. This is going to be very, very big coming up this fall once we're back in flu season, because the flu and COVID-19 have somewhat similar symptoms. And the CDC recently announced before Congress that they actually have now developed a multiplex assay that can simultaneously detect flu and COVID-19. Now, over the last 5 years, I've done a lot of research on multiplex assays relative to group testing. Right now, I actually have an R01 NIH grant that I'm a PI for that's looking at this particular issue, but it was actually obviously written for different diseases. And there are some additional statistical issues that one need to consider as opposed to single disease assays. And that is, we're working with here now a set of unobservable correlated binary random variables that represent the individual disease statuses of every single individual. So binary comes into play because positive or negative for disease. Correlated because each individual is being tested for more than one disease. And unobservable because, again, these assays are not 100% perfect. And what one needs to do is, when you're looking, for example, at the expected number of tests, one needs to now account for the association now between disease statuses due to how these multiplex assays are typically applied in practice on a dedicated system. And so this further complicates how to go about doing this testing. If you're interested in knowing more about this research that I've been doing now for about over the last 5 years, here are corresponding papers on this particular subject. I'm co-authoring all these papers, and myself and my colleagues, we've been very fortunate with this particular work. We've been recognized through a number of different awards, including the Outstanding Statistical Application Award for this particular work. And hopefully then, this fall, when this is now going to come up and come into play, that these methods, we have methods now that are directly applicable to this situation. Okay, so 2 last things to conclude. At JSM 2020, I'm actually giving an introductory overview lecture on group testing. The first part here is going to be very similar to what I just got done talking about here today. But the second part is going to be done by my colleague Chris McMahon, and he's going to talk about the estimation problem of group testing. And there's a lot of statistical research that have been performed, especially over the last 10 years, on this particular problem. And lastly, I will conclude with one more tweet. So I sent this tweet on March 17th, and I said, coincidentally, I'm recovering right now from symptoms like those for COVID-19. I don't know if it is COVID-19 because I can't get tested. Fortunately, I'm doing a lot better than I was a few days ago, perhaps. my research area could have made testing more available. So it's quite ironic that I'm in an area where I do a lot of my research, where my research would have been directly applicable, and in particular would have had an effect on me if group testing would have been applied then. Okay, so that is the end of my presentation. Thank you.
Okay, so we still have like 7 minutes left. So there's some time for further questions if there are from the audience.
Yes, I have a question. Did you turn out to be positive?
Well, I don't know. I haven't been tested, and
you still haven't been tested.
No, I thought, yeah, I never was tested. So I guess I hope I was, because then I maybe kind of got it over with respect to myself. So I mean, it's kind of interesting. I was actually at a point where I told my wife, okay, we need to go to a hospital. I'm really feeling bad. And so she called up the hospital and said, okay, well, give us an hour. We're getting everything ready. And then they called back an hour and they said, sorry, we can't take you at the hospital right now. Wait for it to get worse, essentially. That's what they told her. Fortunately, it didn't. But it's a very frustrating situation to be in. And it's kind of sad that our country has been in that situation.
I have a question, David Donahoe. First of all, thanks for an excellent presentation. I actually have 2 questions, and just the first one is, you showed us a map where people around the world are using your app. What can you say about them actually using pooled testing, group testing in practice? Who's using it, and how have they been successful, if they have been? And then I'll ask a second question in follow-up.
Okay. Unfortunately, that data doesn't necessarily tell me if they're actually using group testing. But I will tell you a few things. First of all, I can often see what organization that they're from. And so I can see, okay, they are from such and such hospital. And so that tells me at least the people who should be considering to use group testing, or at least investigating the app and thinking about it. Now, second, I have been in contact with some people who actually have used it, obviously in Nebraska, but I've been in contact with people in Singapore, people in Australia, and there's information out there too that I don't know if they use my app or not, although I do have visits from their location. There's people who are using it in Germany, they're using it in Israel, they're using it in China. All those locations where they're from, I can see that they're coming to my website too. So I guess that's the best answer that I can give you. I hope, though, in these situations that people are.
So my second question is, there was a Wall Street Journal ad, I believe, a little more than a week ago, full-page ad, was taken out by Paul Romer and his father, Roy Romer. So Roy Romer was governor of Colorado twice and superintendent of public instruction. And Paul Romer is an econ professor. And they're totally all about testing. And in this particular case, they want to reopen schools. And they pointed to information that academic achievement has, gone to 0 basically in the United States in the last 3 months. There's various online metrics of that, and that it's kind of urgent to get kids back in the game. So they want to open the schools in the fall, and they want basically everybody to be tested every day. Do you have any comments either about the initiative, your thoughts on that?
I've been waiting for my university to contact me to help them out, and they haven't yet. But testing every day in terms of, I don't think that would be as helpful as one would think, because again, with the current RT PCR type of application that we're doing, it takes 4 hours to do the test. So if we're really concerned in an everyday aspect, that's somebody's going to be walking around campus for 4 hours maybe. Perhaps there are other kinds of tests that can be developed to take care of that. But I will tell you that my PhD student, Brianna Hitt, who's now at the Air Force Academy, just started last month. Her colleagues have now contacted her about they're going to be testing all the cadets through group testing when they come back. Perhaps in that kind of a scenario, given how that school's structured, it's going to be probably easier to separate out the cadets from the general population. And so, testing maybe once a week or even a longer period of time might work out well. But those are big issues that you're talking about in terms of how we get students back on campus.
Thanks.
So I have a question.
Yes.
So you have this graph about like how well your method the better than other methods, like according to the prevalence of the disease. So do you also have graph for like how do the method compare to one another when you vary the sensitivity or the specificity of the test?
I don't have that graph here, but one could easily construct it. Often, it's easier just to talk about sensitivity specificity case of 1 at the beginning, but one could look at that. And if one wanted to, there are the tools to do that in the bin group 2 package. So sorry, I don't have a graph like that handy to look at.
I see. Thanks.
Do we have any other questions from the audience? Okay, so now it's 5:30, so we should end our seminar now. So let's thank Professor Bilder again for this very timely and interesting talk.
Thank you. Thank you for inviting me.
Yeah, goodbye everyone, and see you next Tuesday.